Hi everybody, I'm Dr. Deed Harrison. I'm president of Chiropractic BioPhysics Seminars and Technique, and I'm also president of Chiropractic BioPhysics, our nonprofit research foundation. If you've been following these weekly video research presentations, you know that I'm going through each one of our 150 plus CBP nonprofit peer-reviewed research publications in a video format. This week we've got a great paper to go through. It's from 2002. It's our clinical control trial on three-point bending lumbar extension traction to restore the lumbar lordosis in chronic low back pain subjects. So let's get started. This paper was published in the Archives of Physical Medicine and Rehabilitation in 2002, volume 83, page 1585 through 1591. I was the lead author. This was a trial out of my early practice in Elko, Nevada, and then Professor Rene Caillet, formerly with USC, my late father, Dr. Don Harrison, and then his PhD advisor, Dr. Tad Yannick, and then the late Dr. Bert Holland, PhD in statistics from Temple University. So the title of the paper, Changes in Sagittal Lumbar Configuration with a New Method of Extension Traction, a non-randomized clinical control trial. So the study methods, here's what we did. We took 48 prospectively selected chronic low back pain subjects. These subjects did not have disc herniation, they did not have radiculopathy. They could have pain down into the buttocks or the top of the leg, but it was localized primarily to the lower back pain. They didn't have what we call true sensory and motor deficits, so we know there's no nerve root involvement. Now, these are chronic back pain subjects. These are not subjects that are acute antalgic and leaning forward where they can't stand up straight. This is the difference in this population. This is not a population that has a recent injury and that's why they can't stand straight and they appear to have loss of their lumbar lordosis. We're not talking about that. We're talking about a true chronic low back pain population. They have loss of their lumbar curve. They have no stenosis, and they have no leg length inequality exceeding 10 millimeters. The leg length inequality is an important variable because it can, by itself, cause chronic low back pain, so we exclude that population. So there's our 48 subjects. Also, in these subjects, what we did, in the first 2 to 4 weeks, the treatment was general spinal manipulative therapy using a modified diversified style chiropractic procedure. So this is long lever bilateral spinal manipulative therapy to increase the range of motion and decrease pain, etc. Okay, so we did 2 to 4 weeks of that, roughly, if you look, 8 to 16 visits. Also in that group, they got traction with a new traction method that will show the three-point bending lumbar extension traction 3 to 5 times a week, pending the subject, for nearly 12 weeks, an average of approximately 37 visits. At the end of the 36 visits. At the end of the 36th session, we wait a minimum of 24 hours later, sometimes better yet 72 hours later, and then we repeat an examination and low back x-ray. So we have an initial exam, including x-ray and pain scale, and then we have 36 visits, and then a day later minimum, we have a second exam and x-ray, okay? So then we can see what did we do with this treatment program of approximately 12 weeks. Then what we did is we got 71%, 34 out of the 48, to commit and come into a long-term follow-up. This was 14.6 months after their second evaluation. So after they stop care, roughly 15 months later, we get a re-examination. So the total study time period is about 1.5 years from start to finish in these 71% of the subjects that came to follow-up, okay? At their follow-up visit, we did an examination and an x-ray. No treatment occurred over that 15 months after the final traction session. Okay, so their final traction session was inside that 36 visits, and then we follow them for a long period of time so we can see, is any correction that we might have achieved, is that stable? That's our treatment group. Now the control group, we're going to take 30 subjects prospectively selected, matched for age, height, sex, and pain, to the 48 prospective subjects in the treatment group. We're going to do an initial and follow-up exam in lumbar x-rays 9 months apart, okay? So we follow these subjects for about 9 months so we see, is their chronic low back pain stable? Does the loss of their lumbar curve that they had initially, does that change on its own or does it remain the same? These are important questions. Now these are chronic low back pain subjects fitting the same inclusion criteria that the prospective treatment group has. This is a non-randomized clinical control trial, meaning the patients self-select what group they want to be in, okay? They say, I want to be part of the treatment group, I want to be part of the control group. Self-selected, non-randomized, prospective clinical control trial. Outcome measures. We're going to look at pain scales and lateral x-ray upright weight-bearing measurements. We're going to do statistical analysis both between and within groups using two-sided, two-sample t-tests, and then we're going to look at the software mini-tab that was available at that time. Obviously, statistical software packages change over time, so that's why I said at that time. Okay, so we look at loss of the lumbar curve. What is loss of the lumbar curve? Well, we look at our idealized elliptical model and our data that we've already gone through in the last 3 videos. So if you look at the last few weeks, videos 18, 19, and 20, you'll see what I mean by our ideal elliptical lumbar model. So we took subjects that had less than the average value of the lordosis minus a standard deviation. And then we also looked at where do these subjects have loss of their curve. So let's say somebody could have a 34 or 35 degree lumbar curve, which is only a little less than the ideal, still within a pain population. However, most of that loss is in the distal lumbar curve, so then we would still include that subject in our population because they've lost their elliptical configuration. Okay, so these are the types of issues that we would look at their total curve, segmental angle of curve, and then we would decide to whether or not they were candidate for the groups. Now this particular example shown here is just qualitatively an example. This is not a case out of the study. This person has a lot of spine arthritis, disc disease, they have spondylosis, they have retrolisthesis, they have a vacuum sign in the disc. This is not one of our treatment subjects or our control subjects. This is simply an image that we put in there to show you the concept. The ideal lumbar curve is here in the red. The back of their vertebral body margins are here. You can see they have an altered lumbar curve. So what we would qualitatively do is decide what part of the lumbar spine do we want to direct our traction force into. Okay, so outcome measures, segmental angles using relative rotation angles, total angle of curve L1 to L5. We looked at sacral base angle to horizontal using the S1 in plate relative to horizontal. We also looked at translation of T12 relative to S1. These are the measurements shown. We also looked at the qualitative ellipse. Do they have a qualitative ellipse compared to our model? That was the previous photograph of an x-ray we showed. Now here's our new 3-point bending traction. Of interest, I'm going to float my own boat here. I was the first person in all of healthcare to design this type of procedure. Nobody else did it before me. In fact, as a student at Life West Chiropractic College, I designed a prototype of this in 1995. Okay, so I started this in 1995, 20 years ago, right? This 3-point bending traction, you're laying on your back supine. We put a strap around the apex of the displaced area or maximally displaced area of the lumbar curve, and then we're going to load that area forward using this strap, loading it at either one of 3 angles. It's either going to go straight up, pulling in the upper lumbar spine, it's going to tilt by about 10 to 15 degrees, pulling in the mid lumbar spine, or it's going to tilt by 15 to maybe 25 degrees directed towards the distal lumbar spine. Now shown here, you can see the angle of this pull is directed towards the distal lumbar spine. I don't have the exact measurement, but it's at least 20 to 25 degrees tilted from vertical towards their feet. Then we have a second strap that we're putting on the upper thighs. That strap constrains the legs and the hips down, and so when I load the lower lumbar spine, it forces the pelvis to tilt forward in deflection, and it increases the distal lumbar curve. Now the weight of the body here is acting backwards. So we call this 1, we call this 2, and we call this 3. So we call it 3-point bending traction. It's also called a transverse load in mechanical engineering types of settings. So this is a transverse load, a type of shear load, okay? Now, you got to be careful when we do this. There's something going on that's creating a lot of extension in the thoracic spine. Some subjects don't need that, so we'll put a strap around the low rib cage. If I tie down the low rib cage before I load the lumbar spine, it'll stop the thoracic spine from going into dramatic extension. It'll cause more of a posterior translation of the rib cage relative to the strap. Okay, now shown in this case, this subject is laying relatively neutral, meaning they don't have a large translation of their trunk forward. Shown in the next picture, you can see we've put a block behind the rib cage, a thoracic translation support block, where we're pushing the rib cage anteriorly relative to the pelvis. This is for people that have loss of the lumbar curve with a posterior translation. Okay, so the setup was unique to the individual characteristics of that patient's spine. 3-point bending traction is the general procedure, but you modify it based on what you see on an x-ray. In other words, you tailor it to the individual. You do not do the same thing to every patient. This is a big thing. All the time I work with patients over the last 20 years, and they've said, wow, this is really interesting. I'm doing something different than somebody else. Even though we appear to be using the same device, their setup is quite different than mine. Yeah, no kidding. That's because your spine is different than their spine. You've got to change what you do based on what you see. Okay, so don't get the idea that everybody gets the exact same setup. It doesn't work that way. You've got to match the setup to the exact patient posture, the exact spine configuration that they have in their low back, and their pelvic tilt. That's what you have to do. Now you'll notice the legs are straight as well. In this case, we want tension on the hamstring muscles so I can get adequate strain on the posterior elements when I'm forcing the pelvis to flex forward. Okay, so we start with 1 to 3 minutes in this traction setup, and then patients over consecutive days are progressed up to where they can do 15 to 20 minutes of sustained loading in this traction. This is the theory of extension traction, why it works. It's sustained loading for 15 to 20 minutes. It causes what we call viscoelastic creep deformation in the connective tissue. All right, the results. This is kind of the meat and the potatoes, right? Results, comparisons of the two groups. Control group here, there's my 30 subjects. The treatment group here, and then statistical analysis between the groups. So here we have their age. These subjects are matched for age. Their height, these subjects are matched for height. Their weight, these subjects are matched for weight. Their initial pain, these subjects are matched for their initial pain. These are moderate intensity chronic low back pain. Anybody more than a 3 and up to a 6 is moderate intensity. This is like the average chronic low back pain sufferer out there. This is like the best bang for your buck. This is why we do this. We're looking at the average person with chronic low back pain. Here's what they have. Let's do a trial on them, okay? Now here's the post-analysis, meaning in the control group, this is 9 months later. In the treatment group, this initial table is after the 36 visits, okay? So you'll look and you'll see the control group, their pain has stayed the same, okay? The treatment group, though, look at their pain. Their pain is over 75% improved. Okay, when you look at this, you go, wow, that's like 80% better. These subjects stay the same. So you do nothing in a control group. If you have chronic low back pain, 9 months later, guess what? You have chronic low back pain. It doesn't go away on its own. Why? Likely you're going to see it's because their lumbar curve didn't change. They look the same on x-ray, so they feel the same 9 months later. It's not going to get better. Don't just do nothing, because when you do nothing, what happens is nothing. It just doesn't get better. It's crazy. You know, I have people all the time, they go, well, you know, when you're doing a study, they select for the control group, and you're kind of like, wow, that's odd, but you're doing a study, so you just, you know, you don't sway them either way. But when you're not doing a study, you look at a patient, you go, what are you thinking? You think it's going to go away on its own? You've had this for 2 years. Don't you want to try something different? Let's try something different. I mean, that's the clinical side of it. Back to the research. The control group, the post-x-rays. So I go on these tangents because it just clinically, I look at this research and I go, man, people aren't getting it. We can do something to help you. This is why we did this research project, to see if we could find a different solution for the condition of chronic low back pain. Okay, so here's the control group. Here's their x-ray measurements initially, and then 9 months later. You'll notice the translation went from 15 to 15. It stayed the same. The AR or the RRA, T12 to L1, that's a segmental angle of T12 to L1, the extension angle. 0 to 0.6 or minus 0.6, no change. You go all the way down. These things did not change. Look at the total lumbar curve. It didn't change a bit, right? Look at their sacral base angle. It didn't change a bit. Their lumbar curve stays the same. Okay? Now, here's the treatment group. The treatment group subjects, if you look at their post x-ray. Okay? Their post x-ray shows dramatic differences in the total lumbar curve. Now, you'll notice one thing. The treatment group subjects did have a statistically significant difference in their lumbar curve compared to the control group. However, the control group still had a statistical loss of their lumbar curve. They were still within the limits of chronic low back pain as measured on the x-rays. Okay, so chronic low back pain subjects in the treatment group. Look at this. ARA, L1 to L5, 22 to 33 degrees. That's an 11.3 degree change. That is statistically significantly different. Look at these variables. Everything changed with the exception of the translation and the top of the lumbar curve. Here's why. Most of these treatment subjects had variations in their translation. So some subjects we wanted to keep the same, some subjects we wanted to pull forward, some subjects we wanted to pull backwards. So if you look carefully at this, you'll notice one thing. The standard deviation is quite different in these subjects. It went from 17 plus or minus 0.31 or 31, 16 plus or minus 20. What that means is the distribution of those translations is narrowing. So although the absolute value of the change shows no statistically significant difference, the distribution of the variation of that change is quite different. And it's because of the different traction setups like I showed you in the beginning. Okay. Also the T12 to L1 RRA, 1.9 to 0.8. 1.1 degree different. That's within our standard error of measurement. It's not statistically significantly different. Here's the deal. This might sound like an excuse, but it's not an excuse. You don't want any curve up there to begin with. You want that to be 0 or 1 degree. So you don't want to see it increase in curve. So what this means is the traction did exactly what we wanted it to do. We didn't want it to increase the top of the curve, and it didn't. So the two variables that didn't change, you might think I'm making a statistical argument and excuse for it, but the reality of it is one of them didn't change, and it's a good thing. We didn't want it to. The other one, the distribution of the curve or the translations is actually much narrower, so the traction did have an effect. However, looking at what we wanted to achieve, most of the increase in the curve occurs, or the change in the curve occurs down in the bottom of the spine. That's what we wanted to see. Okay? So the total angle of curve changed by about 11 degrees. That, at the time this paper came out, it was the largest reported improvement in the lumbar curve ever done. And look at the Ferguson sacral base angle. It improved by almost 5 degrees. Okay, so statistically significant improvements in the treatment group. Now, stop care, follow for 15 months. Let's see what happens. Look at this. No statistically significant differences. All the variables stay exactly the same at long-term follow-up, meaning this thing is a stable correction. When you increase the lumbar curve, it likes it there. It wants to stay there. So 15 months later, it looks really, really good. The correction has maintained. Now, you'll note, we stopped care in these subjects. We would like to get these subjects closer to 40 degrees. However, this is part of a clinical trial, so the patients know that in the beginning. They don't get the option to do a second program of care. If they want to do that, they have to stop care and drop out of the treatment group study, so they can't be part of the study. So these subjects, what they need to do is they say, okay, I've got this change. Now I'm going to stop care and we're going to follow this for just over a year. And it's great that we see stability of the correction. Gender differences, male versus female. This is important to look at. The females in our treatment group you'll notice that they got a statistically significant reduction in the amount of curve correction. Males averaged 12.5 degrees, females 9.8 degrees. It is statistically significant. Here's why. Women's connective tissues are more elastic. They have more recoverable strain energy. What does that mean? Traction stretches you and holds you there. If your tissue is more elastic in its property, then what happens when you let go of the load, it recovers faster. Females notoriously in this age category of about 12 to 13, almost all the way up to about 40 years of age, their connective tissues are very elastic compared to males. They have more recoverable strain energy. It's just the way it is. Biomechanics studies have confirmed this as early as the 1980s. So we see this clinically on average, and our study shows this, women tend to change just a little bit less or slower than a male subject because of the elastic property. So a solution for a female that you're challenged with is to go a little bit longer in the traction time, or they might have to do 2 sessions per day. Now in this study we didn't do that because we're looking at, is there a difference between men and women? What we found is, yeah, women's tissue is more recoverable. Okay, so looking at this, here's a couple subjects out of our study. Here's a male with loss of the lumbar curve, primarily the distal lumbar spine. It's a 16-degree lumbar curve, should be 40. This is after traction. In our trial, we've increased him up to 21 degrees, or up 21 degrees. Now you'll notice that I picked a large change. The average was 11. This guy got 21. So for every average, if you have a high responder, you're going to see a low responder. You never know who that subject is. So this is the purpose of doing a re-examination. You don't know how fast somebody is really going to change, right? Some subjects might only get 5 degrees. Another subject gets, 21 degrees. Now here's the long-term follow-up. Look how great it looks at long-term follow-up. 15 months later, look at what you see. It's a stable correction. Here's another case. This is a male in his 40s. Look at how much reduction in this L3, L4 and L2, L3 segment we have. That disc is not a happy disc. Now he doesn't have radiculopathy yet, but he has some degenerative change there, spinal arthritis and disc degeneration. Here's the post-traction x-ray. You'll notice he went from 19 to 40 degrees. This is another big change of interest. I picked another 21-degree change. Here's the long-term follow-up. Look at that disc at L3, L4. It is opening up. We can change the natural history of this, right? We're improving the alignment. It opens the disc. Chronic low back pain goes from 4 point whatever it was down to less than 1. It's an 80% improvement in chronic back pain. Here's another case, a straightened lumbar curve, and now this one increased up to 29 degrees. Now this person, we don't have a follow-up on them. Remember, only 71% of the cases came back for follow-up, so we lost this case to long-term follow-up. However, he was doing quite well at his re-examination. Maybe that's why he didn't come back. Don't know, because he wasn't part of the follow-up. But you can see this particular sample case, 2A and 2B, great correction. Sacral base angle 17 to 32. All right, study limitations. Look, because it's a non-randomized clinical control trial, we really don't know the answer to the following question. Did spinal manipulative therapy play a role in increasing the lumbar curve? Okay? Was it just the traction or was it the spinal manipulative therapy? Now, I can answer this question in next week's session and the following couple weeks, because I'm going to go through some randomized trials on this. However, at this time, we couldn't conclusively say it's absolutely the traction that restored the lumbar curve, because we did 2 to 4 weeks of spinal manipulative therapy. However, previous studies in the literature, 1990, Plogger et al., looking at the Gonstead technique, segmental specific adjusting, what they found in 1990 in JMPT, no change in the lumbar curve, doing a program of segmental spine adjusting in the lumbar spine. No change, right? Furthermore, 1978, using the technique that we actually did in our clinical trial, these guys found in this paper, lumbar spinal manipulation on trial, radiological assessment, they found no change in the lumbar curve. So we know that spinal manipulation on average does not change chronic low back pain people's lumbar curve. Now notice what I said on average. Every once in a while a blind squirrel finds a nut. I get it. You know, the chiropractors out there, you can all show me cases and send them to me. You know what? I've had a couple of those too. But you can't bank on it. You wouldn't go, oh yeah, I do it all the time. What it is, it's your best clinical case that you got that year, so you're going to, show it off. The reality of it that is, nobody knows why that occurred. If you are making routine changes in the lumbar curve without doing traction, I can tell you right now, it's an acute antalgic patient. This study that we did in 2002, this is the first reported intervention to show statistically significant change in the lumbar curve with non-surgical methods. Now, the spinal adjusting and spinal manipulation in the first 2 to 4 weeks, we believe it certainly helps the process. It makes the joints more mobile. It helps with pain, helps with range of motion. It inhibits muscle spasms. It makes traction easier. It sets the stage for doing traction, but it does not create the change in the lumbar curve. How do we know that? Look at these two previous papers. They got no change in lumbar lordosis. I'm going to harp on this for a second. One of these is a segmental specific adjusting style in chiropractic, the Gonstead technique. Many doctors and many patients love that technique. Great. But you know what? It is not routinely correcting your spine. If it is, it's one of those cases you got lucky, or it's a case that you had an acute antalgic. How do I know that? Well, the clinical trial shows it. That's how I know it. I'm the messenger. Don't get mad at me. If you think Gonstead can change the lumbar curve routinely, then show me a clinical trial. Do one. You know what? It hasn't been done. So right now we say it doesn't work. If you think generalized diversified, like we did in this particular paper down here in 1978, and we did in our paper in 2002, the one I'm going through, if you think that changes the curve, it's your job to do a clinical control trial and show it, because the existing data says it doesn't work. That's why we have to do traction. Hopefully I solved that or answered that for you. Another limitation of the study, we don't know, is it the traction that got the people out of pain or not? Okay? Because we did spinal manipulative therapy in these people for 2 to 4 weeks, we know that that procedure helps chronic low back pain intensity. So we don't conclusively know, is it the traction that improved their chronic low back pain? We can't answer that in a non-randomized trial. We have to look at that later in a randomized trial. Now we do have an answer for that, by the way. However, we know this with spinal manipulative therapy. All the literature on chronic low back pain, if you look at spinal manipulation and adjusting alone, the average patient improvement with chronic pain improves by 45%. That's by doing a program of spinal manipulative therapy for 2 to 4 weeks. You can look at the literature. We did a review, a systematic literature review on that. I'll go through it in the future. However, what I'm going to say here is, in our clinical trial, we got the average chronic low back pain patient to improve by over 80%. In the typical spinal manipulation trial, they only improve chronic back pain intensity by 45%. There is a difference that we're seeing with this traction. I can tell you that when somebody comes in with loss of their lumbar curve and you just do spinal manipulation, you will improve their pain by 40 to 45%, but then now they're stuck with that continued pain. What else do you do? Do you just say, oh, let them go because you're 40 to 45% better? Oh, great, sucks to be you. You know what? Your glass is half empty right now. Okay, good, stay there. Or do you go, you know what, let's try to restore your lumbar curve. Let's get you 80, 90, 100% better. How about that? To me, that's the more logical, idea or concept. But we will look at that in the next couple weeks. We'll look at the randomized trials that have been done on this procedure, and you'll see that using extension traction is a reason why people are continuing to improve their chronic back pain intensity, by the way. Okay, so study conclusions. After 36 sessions with this traction, subjects with chronic low back pain had statistically and clinically significant changes in pain and lateral lumbar x-rays, where we increased the lumbar curve 11.3. You can see I rounded up to try to make it look better, typo, 11.3 degrees. Control subjects, no difference in pain and no difference in their lateral lumbar x-rays, meaning their lumbar curve does not change on its own over time, and their pain, their chronic pain, does not get better on its own over time. Remember, I showed you last week, people continue to suffer for 25 years with chronic back pain. Don't do that. If you're out there and you're listening to this, if you're a patient, don't do that. Don't just go, oh, it sucks to be me, and just deal with it for 25 years. It's not fun. If you have loss of your lumbar curve, seek out a CBP trained chiropractor. They can correct your lumbar curve unless you have major damage to it, right? The only way to know is go consult one of them. At 14 point, this should say 15 months, sorry, it's a typo. Total lumbar lordosis remains stable with no apparent loss of correction. My apologies, I was patching things in as I was going, and sometimes I make some typos. And then lastly, it says, hey, a randomized trial is needed to verify that the changes in alignment and improvement in pain are truly the result of our new traction and not spinal manipulation. We get that, but the reality of it is we don't think it is due to spinal manipulation. The previous studies didn't show that. In the previous studies, they show no change in lumbar curve. And the previous studies only show a 40 to 45% improvement in chronic pain intensity. We got over 80% improvement in chronic pain intensity in this clinical trial. Okay, hopefully you've enjoyed this week's presentation. Please consider the ending message from me in supporting CBP nonprofit research, and if you're a patient, actively seeking out a CBP trained doctor. Until next week, thank you for your time and attention. If you like this information, if you're a patient, you need to go to a Chiropractic BioPhysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy to use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work, okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP nonprofit will get 0.5% of all your purchases, which is a big deal. It adds up.